All right, let's review for this exam. The first thing I'm going to do is get my laser pointer. There we go. Okay, so there's nothing on this slide that you need to know aside from what it is that we're doing. So we'll go to this. Genetics and motor speech disorders. So first, what is the difference between hyper and hypokinetic disorders? Well, hyper means more, and hypo means less. Kinetic means movement. So hyperkinetic is going to be more movement than usual, and hypokinetic is going to be less movement than usual. So a hyperkinetic disorder is typically the vocal folds are moving too much. So they'll adduct, but then they will move around. So they'll adduct and then they will abduct, and then they'll adduct and they'll abduct. Hypokinetic disorder is one where the vocal folds have trouble adducting very much at all, or it takes them longer than you would expect to adduct. So the movement is very slow. So hyper, I mean, we know hyper, right? Hyper. And so that's like hyperkinetic. There's too much movement. They can't stay in one place very long. And hypo is the opposite. It's just too slow. The link between genetics and speech disorders, what is it? Well, it's that we can see things and they can look very similar, right? So we can have a few different clients come in and they can present with very similar disorders. In fact, they can look on paper exactly the same. They can look to us exactly the same. They might have trouble with, we might have two clients and both of them have trouble with certain speech sounds, right? Maybe R's or something like that. And it could be that one just has a standard speech delay and the other might have some sort of genetic abnormality. And when we look at them genetically, when we look at the actual genotype rather than the phenotype, we might actually see that there's two different things going on. And so that one of them might benefit from standard speech therapy, and the other might benefit from something else. It's possible that they would also benefit from the same speech therapy. It's possible that, like we saw with some of the cases that Dr. Peter presented, that there could be dietary changes that need to happen. Sometimes it could be just a genetic abnormality where, that speech disorder might persist regardless of what we do. So there's potentially differences in people that present the same way. And that's why the genetic component is a large piece of the puzzle for speech disorders. Another link between the two is if we know that some speech disorders are hereditary, then we can target some of these children early on. So if we know that the parents had a speech delay or disorder, the grandparents did as well, then we can target that person early. We don't necessarily need to wait the full time to see how delayed they are. If we see a little bit of a delay and it's the same delay that we thought they were going to have because of the genetics, then we might be able to get them early intervention. Early intervention is really key. We want to intervene as early as possible, but we can't always do that because we have to wait until we can see that there's a delay before we can intervene. So that's not early intervention. Well, genetics might be able to give us a way to intervene early. And again, that kind of covers why is genetic testing useful as well. The Babel Boot Camp. You should know this from one of the quizzes, but the Babel Boot Camp is taking children who are not, they're way before speaking age. So they're before that 1 year, where they might start saying their first word. These are babies who are just making noises They're trying to learn how to make the sounds of their language. But if they're delayed in making those sounds of their language, then they're not going to have the building blocks to actually say their first word, and so then they're going to be delayed. So the Babel Boot Camp is getting these babies, teaching these babies and modeling for them how to babble, just how to use their speech effectors so that they have the building blocks for speaking when they're ready for it. All right, so research methods. We've got a couple things on this. Oh, man, I was going to have... Well, you'll just have to watch me do it. So what is the goal of science? To find truth. That's the only goal of science, right? That's all we're looking for. We want to know, is there a link between something? Is there a difference between something? Does this drug or does this intervention, does this treatment do something? And we want to know if it does or doesn't. So we're always looking for, we as in scientists, are always looking for like the truth, right? And there are some jerks who will, do things for publication or grant money, but that's not actually what we're there to do. We're there to find real truths. It's really, the scientific method is like the only really true way that we have to find like universal truths, like what is true about the world, what's true about humans, and things like that. So that's the goal of science. The only thing you need to conduct a scientific study is falsifiability. Right, so we can ask a question. Some guy says that he has a dragon that follows him around. And we can look around and, if we don't see a dragon, then that's falsifiable. And we're like, oh, there is no dragon. This is a falsifiable thing. But if he says there's an invisible dragon that follows him around, we can't see that. Especially if the dragon is like invisible to infrared and stuff like that. And if, the person keeps saying like, well, no, you can't see him with your eyes. You can't see him with like this camera. He's there though. It's not a falsifiable question. You have to have a question that you can say no to, that you could conceivably have a null result. And once you have something phrased so that you could actually find a null result, that's something that you can do science with. So you can say, are these two things correlated? You could find a no, and you could do science with that. Are these two groups different? You could say no, and that's totally fine. Before I got my position at ASU, I was doing some freelance statistics consulting with a couple different companies. One of those companies was actually a group. It was a group called MUFON, and if you know what that is, then you will know why I'm kind of laughing, and if you don't know what that is, I'll show you what that is. So this is MUFON. It's this group who's like interested in UFOs, and they, at one point were like, well, we're interested in like, science, and we want to see like what's actually going on. We have these data sets, and would you take a look at this data set? And I'm like, well, that's kind of interesting, and you're paying me, so that's fine. Then they wanted to know like, well, can you prove that UFOs are real with this data? And no, I mean, like, that's not a falsifiable claim to just prove that they're real. I could, and and I try to tell them this, like, you can't, with this data that you have, I cannot prove that at all. Like, that's not scientific. And then what I ended up doing was something that is much more of a kind of a social psychological thing, where I showed that there's a racial bias of MUFON looking at who is calling in and saying that they've seen something weird. And so essentially what I showed was in zip codes where it's more predominantly white, then MUFON is rating things as more likely to be a UFO than zip codes where it is more predominantly not white, which doesn't have anything to do with UFOs, because you can't prove that. Like, yeah, certainly not with the data that I'm getting. You can't prove it one way or the other. All I've got is like their sighting reports and what they're saying that it probably is. So there's no possible way that you could possibly prove that. But anyway, I thought that was an interesting finding, and I don't know how to publish it because I feel like nobody's going to read it because they're like, UFOs, that's weird. It's not about UFOs, right? But anyway, so that's not a falsifiable question. I couldn't prove that to him, but I could prove that they were racist, so that was kind of fun. All right, so what helps but isn't strictly necessary? Well, feasibility is nice, but not necessary, right? I mean, for us to say that something is an actual testable question, it needs to be falsifiable. For us to actually go ahead and do the work, it needs to be feasible. So it needs to be something that we have the manpower to do, that we have the money to be able to do, that we have the technology to do. So, we could say that somebody went missing, and we think that this person, killed them and buried their body in the desert in such and such a location. That is a falsifiable claim for sure, but it's not necessarily feasible because we need a ton of people to canvass the area and try to find the body that they think is buried, right? So it's falsifiable, and that's great. It's a good claim. It's a testable claim, but the feasibility isn't really there. You'd have to narrow it down, and you've seen the movies where they do that, or the true crime, and they miss things a lot of times because it's just not feasible to get enough people out there to do the job. So falsifiability is the key. Feasibility is nice, but you don't have to have it to have a scientific claim. Well, science is a cycle, right? So the scientific cycle isn't it's not a thing you can ride, but it's a cycle of doing the science, and it starts with a question. Then you do some research into what's previously known. What do we know already? You come up with your hypothesis about something. You collect the data. You analyze the data, and then you interpret the data. And maybe you publish something. But for sure, then you come back up to the top. So if you didn't get the answer that you thought you did, that you thought you should have, then you go back to the top, and maybe you change your hypothesis, or you go back through your study and try to figure out what might have changed. Did I do something wrong? So then you go back that way. Or if you get the right answer, if you get the answer, not the right answer, but the answer that you thought you should have, then you can go back up and try to take it further or find it in a different instance. So we're never done doing science. Think about that. It's very similar to the clinical cycle, right? There's a couple differences, but it's very similar. So you're going to start, when you very first start, you want to gather the specific data before you even come up with a diagnosis. Then once you make a diagnosis, you want to come up with a treatment plan. Then you want to go ahead and give the treatment. You want to collect the data. You want to analyze the data. You want to interpret the data, and then you're going to go presumably back to the top. And when you go back to the top, you're going to did the data. If your treatment worked, you're going to take it further. We got you to say the K sound in isolation. Now we want you to say the K sound in a word. Once you get that, we want you to say it in a group of words. Then we want you to say it in a sentence. And then we want you to use it in, conversational speech. By the time you get there, then you can presumably be done. But it's always a cycle. And you want to evaluate and come back to the top and keep going. The only difference really is that with clinical methods, you can change the methodology in that cycle if something isn't working. with a scientific study, you're locked in as soon as when you're at the top of the cycle, you're locked into your methods all the way through. You have to stick with it until you make sure that it's not working. Well, even if you know it's not working, you have to stick with it, and then, your determination at the end is like, this didn't work, so we're going to go back to the top and do something different. In an experiment, you have a few different types of variables. So you have an independent variable. Your independent variable is not dependent on what's going on in the research. Your independent variable is based on you. It's something that you're changing. So you have the ability to change it. It's kind of dependent on you changing it, I guess, but it's the independent thing. You're changing it independently of what happens in the experiment. The dependent variable is the outcome. It's what you're measuring. It's the one that depends on what you've done to a different variable. We talked a lot about milligrams of a drug. And so the independent variable is how much of the drug you give. 0 milligrams, 10 milligrams, 20 milligrams. You're changing it, and you're giving it to somebody. The dependent variable is the measurement of whatever you're trying to change. So if it's headache pain, the dependent variable is like the person's rating of how intense their headache is. That depends on how much of the drug you've given them in the first place. And then a control variable is something that might impact the study that you've held constant because you think it might impact the study. So you might want everyone you give them this drug for headache pain. You don't want them to smoke or drink or anything that might give you like an allergy type headache. You don't want somebody to go gardening because that could give them an allergy headache too. So while you're doing this drug trial, you don't want them to garden, you don't want them to smoke, you don't want them to drink. So you try to control other headaches. You don't want somebody to be in extremely bright light because that could impact the headache as well. So these are all things that you're trying to control to make sure that your dependent variable is measuring the independent variable and not something else. Okay, and then the last thing here is, what is a p-value? I mean, it stands for probability value, but that's not, you can know about it as a p-value. You don't have to call it a probability value. But what's important to know about the probability value is, what's important to know about p-value is that it actually is not what a lot of people think it is. So a lot of people think that it's the probability that that looks like crap. A lot of people think that it's the probability that two means are different from each other. So these are two groups. We can say this is like the placebo group, and this is our 10 milligram group. A lot of people think it's the difference so here's where the mean is, right? So maybe this is, headache severity is lower in this placebo group than it is in this 10 milligram group, which would be weird. So a lot of people think that the p-value is related to the difference between these two means. It's related to it, but it's not measuring it exactly. No, what it's measuring is something different. So both of these two distributions, actually we'll keep that. Both of these two distributions have a mean, which is right at the center of the distribution, and a standard deviation, which is just how much variance you can expect around that mean, how much it's expected to vary. So they both have that. Now, you would take this distribution right here, and you would say, well, what if instead of the 50 people that you had in both of these groups, you had 10,000? So I'm going to make a line here that separates these two from this other thing over here. So what if you had another distribution that's just like that first one, but instead of 50 people, you had 10,000. You would have a mean that's in the same place as this mean. You'd have a standard deviation that's the same width as this standard deviation. It'd just have a whole bunch more people in it. You would sample from this. You'd pull handfuls from it, handfuls of 50 from it, and they'd usually look like this one over here does. Sometimes they'd be in slightly different places. The p-value, the probability value, is how often you get this distribution by randomly selecting from this distribution right here. So you'd have to be like way down over in the tail somewhere over here and pull all of your people from there to get this distribution. So it's very unlikely. And that's why the p-value is low, because it's really unlikely, it's a really small probability that you'd get this group by pulling it from this group, which is likely where this group came from. So that's the p-value. If you want to shorten that, you could say the p-value is the likelihood that the second group came from the tail of the first group, that they're actually the same, and that the second group was selected from the tail of the first group. All right. Now you guys did something interesting. I had you guys do something for extra credit, which was I had you rate cauliflower and ice cream. So you can see here that people who, green is going to be people that saw cauliflower first. They rated cauliflower first. And blue is people who rated ice cream first. So you can see that there's a little bit of a difference. Cauliflower first, cauliflower is rated a little bit higher. And then when cauliflower came after ice cream, it was a little bit lower. And then you see that also when ice cream comes after cauliflower, it's rated higher. When ice cream comes first, it's rated just a little bit lower. So there is a little bit of an effect of the presentation order. That is I'm ahead of myself because my camera stopped recording for some reason. That is an order effect. Right here, an order effect. So essentially, an order effect is just that the presentation order matters. You can imagine that if you were asked to run a 9-minute mile, you might be like, well, all right, that was a little difficult. I might rate it as a 6 or a 7. And then immediately after that, you're asked to run a 7-minute mile, and that might be a 10. However, if you were asked to run the 7-minute mile first, you might still rate that as a 10, and then you're asked to run a 9-minute mile, and that seems a lot easier in comparison to the 7-minute mile. So that's an order effect. Just the order matters. A practice effect is when you're just getting better at something. So free throws is a really good example of this. Maybe you throw the first one and it doesn't get anywhere close. You throw the second one, it bounces off the backboard. The third one actually goes in. And this is because you are getting a little bit better as you're doing it. So you're practicing, you're doing better. That's a practice effect. A fatigue effect is kind of the opposite. You're getting worse at something. And that might be because you're getting tired, either mentally tired or actually physically tired. The race example, you might be physically tired. One thing that I like to do when I run is I like to look at my quarter-mile times and just to see, how fast I was going at each quarter mile. And, they get slower over time. which is to be expected. But that's a fatigue effect. Now these other things, this between and within group. Oh, I wanted to mention something really quickly about practice effect. So you're not thinking about the GRE yet. That's the exam to get into graduate school, but you will be soon, because you need it to get into your master's program for being an SLP. It is a different test than usual. It's not necessarily hard if you are a good test taker. Then you'll be fine. If you're bad at standardized tests, it might be a little difficult for you. But one thing that is a published effect is if you don't do very well, the published effect is the best predictor for doing well is taking the exam a second time. And that's because it's a different type of exam. It's all computer-based. It's not Scantron like what you've been doing, throughout most of high school and college, which is all Scantrons. I think the SAT is on computer now, but that is also probably similarly problematic because it's on computer, just like the GRE. So, sorry, I'm starting to lose my voice. What was I saying? So, the GRE, right. You'll do better if you take it a second time. It's a different format, and the reason you do better is because the second time you go in to take it, you're actually focusing on the material and not all of this different stuff with the setting and all of the weird TSA-like security procedures that they make you go through before you can actually take the exam. So that's all old news by the time you go to take it your second time, and then you can actually show how good you are at doing the actual test, and that's a practice effect. So capitalize on it. If you don't do very good your first time taking it, if you do fine, then why take it again? But all right, so now between groups and within groups are different ways to set up an experiment. A between groups method is where you have two different groups of people. So think about you guys when you were answering the question about cauliflower and ice cream. One group got cauliflower first, the other group got ice cream first. I couldn't, if I want to look at, how you rate them differently based on order, I couldn't give one group, put you both in the same group, and then give you cauliflower and then ice cream, and then give you ice cream, then cauliflower. You'd remember your responses, and you just give me the same responses. I had to break you into two different groups. So I have two groups, and the difference is actually between these groups. I can take an average here and an average here and look at the difference between those groups. A within groups design is different. That's where you take one group and you actually want to look at the difference between the one person at two different levels of something within that group. So you take all these people and you look at how each person in there changed in relation to themselves. That's a within group design. Think about our headache medicine example. So if we had all these people that get migraines, and what we want to do is we tell them, the first time you get a migraine, we want you to take this pill, and that's a placebo. Of course, they don't know that. The second time you get a migraine, we want you to take this pill, and that's 10 milligrams of our new wonder drug for headaches. And some of those people might get the actual drug first, and the others, and the placebo second. The others get the placebo first. That's controlling for the order effects that we were actually curious about in our cauliflower experiment. Because what we're actually curious about is, does our drug do better than the placebo? But we're not comparing one group against another. We're not comparing a placebo group to a drug group. What we're comparing is how effective those two drugs were, the placebo and the real drug, for each individual person in this huge group. So how did this person's headache feel differently from placebo to real drug, and then this guy, and then this lady, and then this person over here, right? And so we're going to take all those and average them together, and that's a within group design. Everything's happening really within the person, within one person, but you group them together to get a good look at if that person is, weird, or if they're the same, So hopefully everybody's kind of functioning pretty much the same. You might get a couple outliers, but that's a within groups design. And then again, between is where you have two groups that have done different things, and then you're comparing those groups to each other. The last thing here, I did not touch on this at all when we went through the research methods lecture, this AAXBB design. And it's not on the test, but I wanted to mention it because we've talked about clinical methods now. So what this is, the AAXBB, AA means your pretest. You're going to do a pretest and the pretest. And then the X is your intervention. And then the B is your post-test. So you're going to post-test, post-test. So essentially what you're going to do is pretest and then pretest again. Like let's say you're at a school. You bring a kid in and you give them their first speech pretest. You give them pretest. You're going to collect maybe speech samples here. Then you want to bring them in again and you want to collect the speech samples again. You haven't done anything yet. You just want to collect speech samples. Then you do your intervention. Then you give them a post-test. You bring them back in a week later. You give them another post-test. And what this does is it allows you to see what the practice effects are, or the fatigue effects, or anything. And then you can kind of take those out of the actual intervention and see if you did anything. One thing that you don't want to do is have an intervention that's actually helping, but there's a fatigue effect going on, so it looks like it's not helping, and then stop using it. If you do this pretest, intervention, post-test design, you can account for fatigue effects. And then if you subtract this fatigue effect from the actual intervention, you might actually see that the intervention is still helping. There's just a large fatigue effect. The other thing is there might be a practice effect and your intervention actually isn't doing anything, so maybe you need to figure out a better intervention. So this is a really good design to use when you're in a clinical setting. Of course, if you have time. A lot of people have too much of a caseload to be able to do this. One thing that you might see is that if your client, the kid comes in at the end of their day, there's a huge fatigue effect for them in terms of things that they're being asked to do. So they have all this school, and then at the end, they're going to work on speech. So maybe they're not doing very good with things they have a problem with. And maybe if there's a way that you can then give them another pretest at the beginning of the day to actually see how they're doing at the beginning of the day, you can get an idea of what the fatigue effect is of just their day. And then give them an intervention. And then give them two post-tests as well at different times and gauge how they've changed. Okay. So clinical methods, we talked about most of this already. It's also a cycle. And the main difference between research and clinical methods is that you can change what you're doing with clinical methods to accommodate your client. The reason for this is because when you're a clinician, your responsibility is to your client. You want them to succeed. You want them to be, in a comfortable place, doing something that they are comfortable with and that's actually helping them. When you're a researcher, your responsibility is to the integrity of the study. And so you can't change your methods because you need to show that that either works or doesn't. You need to see it through and then report the results. So there's a slight difference there, and that creates a slight difference in the methods. But it's just depending on kind of like what our focus is at the time. Our focus is on the client, our focus is on the research. You can be a clinician who's also doing research. That just means that you switch your responsibilities depending on what job you're doing that day. So if you're with a client, your responsibility is to them. If you're doing research, your responsibility is to the integrity of the research. And then the stages of clinical methods, the first thing you want to do, it's not a diagnosis, right? The first thing you want to do is you want to look at What is the difficulty without a diagnosis? So let's say if you're in a school, you want to say that this kid presents with kind of slushy S's. Every 5 or 6 times he says S, it's kind of a slushy sound. That's identifying just the problem. If you're in a clinic, like maybe a nursing home, you want to say that this person seems to aspirate their liquids very often. So water and tea, they might aspirate they'll often. You don't want to say that there's weakness swallowing because you don't really know yet. You just want to identify the really core problem of what's going on. Then analyze what you've written, then come up with some sort of diagnosis. If you're in a school, if you're dealing with a swallowing or voice disorder, you make your recommendation to the doctor of what the actual diagnosis, could be, or just present the actual issues to them, depending on how the role and responsibility goes for you as an SLP where you are. You can't always diagnose. You can with speech disorders, but not voice disorders. And swallowing disorders are odd. So that may be changing also. By the time you guys are SLPs, there could be differences, or maybe it'll be the same. You'll just have to see. And you'll get all that, in the more undergrad classes, you go higher in the ranks, and then also your grad classes, which will be more up to date because you'll be closer to being actual practicing SLPs by then. But anyway, the first step is, what is the actual problem? Then investigate it, then come up with a diagnosis. Then you want to come up with a treatment plan, set some goals. Then you want to enact the treatment, collect data, analyze the data, and then go back to the top and start over. Or perhaps they might be done. So you might want to say, like, let's work on K's in isolation. And those K's are good, so you come back up and say, let's work on saying K's within words. And then that's good. We want to say K's within a phrase, K's within a sentence. Say your K's correctly in conversational speech. And by the time they've mastered that, you have an end to your cycle. Science doesn't have an end. It's a never-ending. Every scientist will die before science is solved, which is, I guess, good. All right, so AAC devices. First, Asha has noted that communication is the essence of life, right? So this relates to something else that we've talked about, but I don't remember what I was going to say here. But essentially, being able to connect and describe things that you need is one of the key... man, sorry. I need to take a drink or something, but I don't have any water around here. Anyway, being able to communicate is one of the key things that you should be able to do as a person. It's really, the essence of living. Communication in some form, not necessarily spoken or written, but some form of communication. Oh, I remember what I was going to say here. We talked about this when we talked about patients with aphasia. Remember, you might not, it's very unlikely that you'd be able to get these patients back to their pre-aphasic state. You're not going to have them speaking correctly, probably ever. But if you can teach them how to say one word, get one word back for them, even, something that's meaningful, somebody's name or something that they like to do, that one word can really enhance their quality of life. And that's key, right? Because this is the goal, is the quality of life, and the communication is really the essence of that. So AAC devices are not just used for communication, they're actually used for communication and comprehension. So they're kind of twofold devices, right? They can be used both, they can facilitate both. There's two types of devices. We've got conventional ones and non-conventional ones. Conventional essentially just means the way that it functions is the same way that our language is functioning. So if I was going to type something out with my keyboard, that's conventional. A chordboard has symbols that correspond to words, so you're going to point to symbols, and that's going to create a sentence, essentially, right? So you could have somebody point to, like, I think you suck, or something like that, right? So that's a full sentence. They're pointing to symbols that will make a sentence. It's conventional. Non-conventional is a little different. That's where you've got something like a code. I've got this packaging here that'll kind of show what I'm talking about. The shape of this packaging is odd, but it's from this little candle light that I found in my closet that I'm using to light up my face. So, anyway, a non-conventional device might be something like this plexiglass that could be between you and the speaker, or the communicator. And they might look up in the corner, and if they look up to this corner, it means food, and then they look over here, and that means candy. But maybe they look down here first, and then they look up here, and that means book. Like they want you to hold up a book so they can read it. And that's a very non-conventional way of communicating. It's a special code that's derived just for that communicator and their communication partners. So that is a non-conventional method, non-conventional AAC device. AAC devices absolutely do not hinder the development of spoken language, if spoken language development is possible. A lot of parents are reticent to use AAC devices because they think that, this is an easy thing, an easy method that their child has, and they're going to use that instead of practicing their communication. But that doesn't seem to be the case. There's a lot of studies that show that that's not what's happening. In fact, it's bolstering their desire to communicate. The more practice they get with communicating, the more they enjoy it, and then that can help them learn to try to communicate in different ways, so including spoken language. One of the keys to getting children to use their AAC devices is modeling. And this isn't just true for children. I mean, this is true for anybody who's given a new AAC device. They need to be shown how to use it. So you can show them, and then you could say, go practice saying this 1,000 times. But if they're doing it alone, learning how to use it, it's not working as well. It's not going to work as well. You can try to teach children the reason why they might need to use it, and that doesn't work as well either. What works the best is just you showing them how to use it, you using it to communicate with them, and getting the parents to use it to communicate with the child as well. Once they're showing them how to use it correctly, then the child will pick it up too. It's no different. I mean, we do this with behavior all the time. We're always modeling behavior. We're modeling normal speech when we speak to children. We're modeling how to wash our hands for 20 seconds, all sorts of things like that. And they pick up on it the same way. And again, it's not true it's very true for children. Adults may already understand why it's important and they might not need the modeling, but that isn't necessarily true. I mean, you've got stubborn stroke patients who might not want to use it, but if you can communicate with them using the AAC device, they might want to pick it up and communicate with you and other people that way too. Direct and indirect access. A direct access just means that you can really directly get to the piece of information that you want to get out. So on my computer, I can touch my keys. That's direct access. If I have a chordboard, I can point to the symbol that corresponds to the word that I want to say. That's direct access. If I was using eye gaze on my screen to point to a word that I wanted the computer to say for me, that's direct access. Indirect access is when you can't pick out individual pieces of what you want to say. This is when you have severe motor problems. Maybe only one hand works or one foot. And what you do is you use just that one to click something or bend something or turn something so that you can go to one half of the screen and then a quadrant of the screen and then get smaller and smaller from there and eventually land on the word that you want to say, all just with one clicker or joystick or something like that. So that's indirect access. Okay, voice disorders, also known as dysphonia, kind of like what's going on with me for some reason right now. We do know for sure that sometimes voice, speech, and swallowing disorders can co-occur. Think about this like acid reflux based disorders. So somebody might be having acid reflux. This can affect the vocal cords. They might have a gravelly voice, and also it's possible that there could be some weakness associated with their swallowing reflex. So they can co-occur. It can all be from one cause. So they certainly can co-occur. If you have physical abnormalities, like growth abnormalities, that can lead to swallowing difficulties and speech difficulties as well. So they can co-occur, but that doesn't mean that they always do. I mean, certainly we can have speech disorders and no swallowing disorders. You can have people with swallowing disorders and no speech disorders. But they can co-occur. Some common voice problems are Reinke's edema. That's usually caused by smoking, and that's just swelling of the vocal folds. There's a lot of things that can cause swelling. Talking too much, like I'm doing right now. I've recorded too many videos today. That can cause swelling as well, but Reinke's edema is a long-term swelling that's usually caused by smoking. Nodes, vocal nodules, or if you've watched Pitch Perfect, nodes. Those are little nodes, basically. They're like small inflamed bits of tissue that can show up on the vocal folds, also sometimes known as vocal polyps. They'll show up on the vocal folds and they'll cause a weird sound, kind of a gravelly sound, a strained vocal sound, and that's because the vocal folds aren't vibrating like they should. And they might not be adducting as much as they should either. So they're kind of just completely changing the way that the vocal folds work, essentially. They're not letting them work like they should. Those are often benign. It's usually from overuse. And one of the things that you do to get rid of those is just go on vocal rest and they can go away. You can have them surgically removed, and if they persist, they're usually surgically removed, but typically it's just vocal rest and they'll go away. Hemorrhages, that they'll usually go away as well. Hemorrhages just means that there's not usually blood flow on the vocal ligament, but something can tear in there from vocal strain, and then you'll actually see blood leaking onto the vocal folds. It's not in the throat, it's inside the vocal fold, and what that does is it causes the vocal fold to become more stiff. It's swollen. You think about if you injure your elbow or your knee or basically anything, there's a swelling response, and that's blood flow and going to the area and causing it to swell up. And so if you have a joint that's injured, it gets stiffer. This is true for the vocal folds as well. They get stiffer and they don't vibrate like they should. And that difference of vibration is what actually leads to the change in vocal quality that would lead someone to go have their vocal folds looked at, and then you'd notice that there was a hemorrhage. Some of the voicing tests that we can use One is just saying a consonant. We should be over 10 seconds for that. By a lot. A lot, most of us are, or way over 10 seconds when we tried it in class. I think most females are over 30 seconds and most males are over about 45 seconds. Pretty sure most of us were like way over that. I know I was on the minute side, and some of you were as well. So we have strong lungs, which is good. That test, the test, is looking at our respiratory function, and so that's why you want to be above 10 seconds. If you can't go longer than 10 seconds, there's some sort of respiratory dysfunction, and that could be the basis of the voicing problem. The S and Z test, similar method. You go S or Z, and you look at the ratio between those. So if you have 30 seconds to 31 seconds, that's approximately 1 to 1, and that's where you want to be. Because really there's no difference between those except that you're adducting the vocal folds while you're saying the S. So you're going S, and you're using air. Air's coming out and passing through where, your tongue is in a dental position. The air is flowing through your trachea. It's coming out. Then you're saying an S. For a Z, you're adducting the vocal folds and doing the same thing. So you should be able to produce those equally as long with a tiny bit of slop in there. But approximately 1 to 1 is exactly what you're looking for. If they're not 1 to 1, likely what's going to happen is that the Z will take a little bit shorter time, so you'll end up with a higher S ratio, and that's because there's some sort of issue in adducting the vocal folds. Maybe they adduct too much and like too tight, and it takes a little extra work to get the Z to start, and then too much air comes out, and then you can't say the Z as long. So that's another voicing test. All right, so this is our last slide. Swallowing, which is also known as dysphagia, but not dysphagia. Careful, look at the spelling there. I'm not going to trick you with that on the exam, but you should know that dysphagia is a speech disorder. It has the same root as aphasia. And in this profession, you're absolutely going to hear it. But you're also going to hear a lot of times dysphagia with a G here. So dysphagia with a G is a swallowing disorder, and dysphagia here is a speech disorder, a language disorder. So know the difference between the two. Obviously, if somebody just says it to you and you have no background information on what they might be saying, you won't know. But most times if somebody says dysphagia, it's the swallowing disorder, not this one. They'll usually say aphasia or something a little bit more specific. But it's good to know that they both exist. What can happen when we have swallowing trouble? Well, a lot of things, right? I mean, number one, we're not going to get nutrients. We're not going to get liquids, so we're not going to be properly hydrated. I think that's maybe what's going on with my voice. I'm not properly hydrated. But all sorts of other things too. Weakened immune system from not eating the correct things. Higher medical costs overall. It was an interesting thing that Joshua said. What else? I had a bunch of things that I wanted to mention about this. Oh, isolation. If you can't swallow, you can't go out to eat. You can't go out and hang out with your friends. So you get isolation. There's a lot of depression that co-occurs with this as well. Other, psychogenic kind of, well, psychogenic means it's caused by psychological trauma, but other psychological problems that come along with this as well. Depression and isolation, stuff that goes along with that. Just a lack of like anhedonia, you don't want to do anything, this can come along with swallowing as well. These are all problems that are associated with swallowing. Also, sometimes, death. So, swallowing problems are very important to address. The order of the swallowing stages is going to go pre-oral, which is when you're kind of like looking at your food, you're thinking about your food, you're smelling the food. That's pre-oral stage. You're going to start producing saliva here, even though the food is not even in your mouth. But you're getting ready to have the food in your mouth. So then you go to the oral preparatory stage, and the preparatory just means like you're preparing the food for to swallow it. So you're chewing it, you're turning it into a bolus, which is a mixture of food and saliva, kind of a ball. It's Latin for ball. That's essentially the oral preparatory stage. Then you've got the oral propulsory stage, and that's when you're pushing the bolus back and getting ready to swallow it. And then you've got the pharyngeal stage, which is when it's, out of the mouth now, it's in the pharynx, and you've gone into this kind of involuntary part of swallowing. So everything up to then, the chewing, the initiation of the swallowing, there's a lot of voluntary components to that. But once it gets back here in the pharynx, in the pharyngeal stage, that becomes an involuntary portion. So I've answered my next question to you guys here. Voluntary or involuntary? It's both. What can cause dysphagia? Well, lots of things can cause dysphagia. Trauma can cause dysphagia, and I mean physical trauma to the bone structure can cause it. There can be trauma to the brain, so you can have, TBI, stroke. This can all cause swallowing difficulties. Certain types of infections can inflame the nerves and lead to swallowing difficulties. Certain medications can change the neural circuitry, or affect the nerves that are necessary for swallowing. All of these are potential causes. Fees and barium swallow. Things that you should know about these. Fees is the endoscopy. It goes up through your nose and looks down. That doesn't require anyone else to be there for you to use. Fees you can do as an SLP. You can take this little cart into somebody's room and you can just like look down there, shove this thing up their nose and look down their throat for basically as long as you want. There doesn't need to be a doctor or an x-ray tech or anybody with you for fees. So you can hang around and you can have them do all sorts of little exercises and you can get a good idea of what their swallowing problem might be. Fees is also used in voice disorders as well, and it has a similar function there. You can take it and use it as long as you want, have them do all sorts of vocal exercises and get a good idea of what's going on. The barium swallow is a little bit different. That does require an x-ray tech to be present. Because they're swallowing something that's really dense and not reflective to the x-ray. Or actually, sorry, it is reflective to the x-ray. So they need to be, at the x-ray machine when they swallow it so you can get a good picture of that barium going down. So that one you can't use as long as you want. But both of them do provide a really good view for you and the patient of what's actually going on. It's really good, two different views of the actual swallowing difficulty. A lot of times you might use them together. So do fees, have a good idea of what's going on with fees, then you might take them back to do a barium swallow just to double check yourself. But it gives you and the patient a good view of what's going on. It's important that the patient knows too, because once they can see the problem and identify where it is in their swallow, sometimes, depending on their ability, they can work to correct it themselves too. along with you. I mean, you can help direct them, but once they know what they're doing wrong, and then also they can see what they're doing right, then that's good. Then they can learn better that way. Let's see, was there something else I wanted to mention about this? Oh, well, no, I think we're good. Okay, so about the exam really quickly, there's 40 questions. Each one is worth 1 point on Canvas, but what I'm going to do is I'm just going to take the proportion that you got correct and incorrect and multiply that by 100. So it's going to be out of 100 eventually, but right now it'll show up as out of 40, but it will count towards the 100 points of your grade like it should. It's just not going to look like it right at first. But you will get a percentage. The percentage is going to remain the same, right? So if you got a 98%, you're going to get a 98% no matter what. We'll tweak the actual points to be worth 100 like they should be and not 40. All right. So, there's 3 extra credit questions as usual. Each one is worth 1 point. There's actually 2 parts to one. You can get up to 2 points for one of them, so be on the lookout for that one. Some of the questions, most of them are multiple choice. Some of them are multiple answer, so you'll select all that apply, or sometimes it'll say select 2. So be on the lookout for that. If a question says select all that apply, you will be able to select multiple things. But a lot of them are just multiple choice. There's no matching on this exam. It's all multiple choice or multiple answer. And good luck. I can't think of anything else that I was going to tell you. But if you have questions, email me, email Amy, email Abby. One of us will be able to answer your question. All right. So these slides are already up. Go ahead and take a look at these. Look at this video. I mean, you already have, but this will be really good for studying. And also take a look at your quizzes. Some questions have shown up again. So that's another good resource. Okay, good luck.